I'm Millard Sussman. I'm a member of the Retirement Opportunities Committee, which is the organizer of this webinar today. And it's my honor to introduce our speaker, Dr. Adam Konopka, Department of Medicine. He is the director of the uh, musculoskeletal aging and metabolism laboratory in the Department of Medicine, and does research on aging of muscles and arthritis. Uh, he is interested in learning the mechanisms of aging that affects muscle strength, muscle loss, osteoporosis, um, arthritic changes in the skeleton. And he's here to talk today about a drug that uh, has been shown in the laboratory to extend the lives of a number of experimental animals and to uh, contribute to their quality of life as well as the length of their lives, putting off some of the effects of aging on our aging bodies. And he's going to tell us about those experiments that he's been doing about the drug trial that he has underway. So it's my great pleasure, and with gratitude, I introduce Dr. Adam Konopka.
All right. Well, thank you for having me here today, and I'm excited to talk about some of the background work that has led to our clinical trials testing whether the drug rapamycin might be able to extend healthy aging, particularly in humans. So to get started, one of the one of the main, I think, focuses of our lab is understanding aging and why do we get older and why are there these increased risks for chronic conditions? And so on the y-axis here we have the disease incidence rates. So basically you can pick your condition that you are most interested or aligned with. And there are generally an age-related increase in a number of chronic diseases or conditions. So think about arthritis, for example, heart disease, type 2 diabetes. They all might follow different trajectories, but they generally increase with increasing age. And a lot of adults have two or more chronic conditions. So it's not just one kind of chronic condition, it's multiple. And this becomes, problematic not only on a personal level for everyone trying to manage and deal with these, but also from more of a population level. In 2016, the number of children under the age of 18 outnumbered adults over the age of 65. However, very soon that we're kind of undergoing this population shift where we will, for the first time, have more individuals over the age of 65 compared to children under the age of 18. And so with this kind of shift in population aging, that will lead potentially to increases in medical care and costs. The next kind of question is, well, we're going to get older. We all get older. We all have birthdays, and each year we add another number to that. But the question is aging and lifespan modifiable? And I don't know if we can actually answer that question or not, but there was initial work back in the 90s where they were studying C. elegans, which is a model of that can be used to study aging. These are another word for worms, basically. And this is a survival curve where you have the percent of worms that are alive and then their age. And this is in days. These are short-lived animals. But what this research group found is that when you manipulate or delete a gene involved in growth and metabolism, worms double their lifespan. And these data indicate, at least in preclinical models, that while we are going to get older, the time doesn't change. This may suggest that aging can be slowed and that lifespan could be extended. And so this is pretty exciting with the idea that maybe we can modify how people get older. And so today, hopefully with the intro slides, you can kind of appreciate that as we get older, there's an increased risk of chronic conditions. It's not to say that as we get older, there's also not some good events that happen. Obviously, there's some really significant lived experiences that happen as we get older, but we are going to focus on how we can improve the overall kind of health of individuals. We are going to review the what's called the geroscience hypothesis. So geroscience is really the intersection of gerontology and more of the basic biology that underlies some of these changes with aging, and then how we use what we call a translational research approach or translational geroscience approach. And that will all set up how we're taking data that has been studied in experimental lab animals and testing how a leading drug candidate called rapamycin, how we're testing that to see if we can improve health of adults. And so the geroscience hypothesis posits that there are multiple interrelated fundamental biological pathways and mechanisms that become dysregulated with aging. And as they lose their normal function, this leads to a loss of physiological function or physiology. So think heart rate, blood pressure, glucose metabolism, etc. And so as the biology becomes dysregulated, we lose physiological function. This increases the susceptibility to more chronic conditions with increasing age. And this also identifies that it may not be an individual disease-specific kind of mechanism, but there is something conserved or fundamental across multiple age-related conditions, since age is the number one risk factor for all of these conditions that we're seeing here in this figure. And so to study these kind of relationships between the biology and the physiology, we take what we call a translational geroscience approach. So we have studies ongoing in the lab that use culture experiments, so tissues obtained from mice or humans, where we study them in a culture dish in highly controlled settings. We also have studies in rodents, non-human primates, and then human clinical trials. And the idea is that if we can identify how different biological processes are being regulated in a culture dish, in different rodent models, non-human primates, which are our closest evolutionary companion or species, how can we take the information that we've gained in these what we call preclinical models and apply them to test different compounds or lifestyle modifications that can improve the health of humans and human clinical trials. And so today I'm going to talk about how we are kind of interrogating the underlying biology of aging with the hope that we can improve or maintain physiology. And before I get into that, I just want to review a kind of theoretical concept that was discussed in the literature recently, where it essentially defines the lifespan into two different distinct periods of life. The first being called health span. And this is generally described as the maintenance of function, no chronic diseases or disability. And so, in other words, a high quality of life. Then there's a subsequent period of life that is described by the onset of one or more chronic conditions like arthritis, type 2 diabetes, cardiovascular disease, etc., and or mobility or disability limitations. And so the idea for us is that we are really interested in intervening in human clinical trials where people are still healthy, but they might have risk factors or they might be, they might start seeing some declines in their functional capacities, but they do not yet have overt chronic conditions. Because the idea is if we can intervene at this period of time in life, then perhaps we can extend the health span, so having more years with high quality of life and compress the time spent with disease or disability. And so I'm going to be mainly focusing on rapamycin, but surely other lifestyle factors can also play a role in this. And so one of the reasons we are focused on rapamycin is that this is actually an FDA approved drug. So from a regulatory and safety perspective, there's a lot of data from different patient populations, and it's also easier to repurpose a drug, especially one that has some really compelling data to its name, to implement in relatively healthy older adults. And so rapamycin, also known as sirolimus or sirolimus, and its analog. So these are their kind of cousin or second generation rapamycin agents called everolimus or temsirolimus. They're approved to prevent organ transplant rejection. So most commonly used in people who undergo kidney transplant surgeries. So this helps prevent the rejection of the new organ. And these drugs are also indicated for a variety of different cancers or in different cancer cocktail treatments, as well as some other less known indications. So importantly, I'm going to be talking about the impact of rapamycin in the context of aging, but it's important to note that this is not FDA approved for aging or any other disease. So everything I'm talking about is under the description of what's called off-label, meaning it's not necessarily FDA approved for that indication. And so rapamycin, its primary mechanism of action is to attenuate or inhibit the mTOR protein in the body. And this mTOR protein is in all of our cells and is conserved across different species. And this protein was actually identified from its use with rapamycin. So it's named after the drug. And this mTOR protein is involved with growth, metabolism, and it essentially increases with increasing chronological age. So as we get older, the activity and the signaling through this mTOR protein increases. And rapamycin, for patients, they take anywhere from 2 to 10 milligrams per day of rapamycin or its analogs. So that's going to be important as we move forward and talk about our study designs, which use a much smaller dose of rapamycin. So the idea is that if rapamycin inhibits this mTOR protein and it increases with age, perhaps attenuating that increase or correcting its hyperactive state could slow the aging-related onset of multiple chronic conditions. And so I think the excitement around rapamycin is because it has been shown in multiple laboratories across the world to extend the lifespan in different experimental animals, from flies, worms, different strains of mice, and more recently in a non-human primate model. So non-human primates can live for a significant portion of time. And again, as I mentioned earlier, evolutionarily, they are the most relatable to humans. And so this is all really exciting data. And the figure I've shown here is a survival curve. So we have survival on the y-axis, and then the days on the x-axis here. And these data are from the NIA-sponsored interventions testing program, which has 3 sites around the country that use these what are called heterogeneous outbred mice. They're supposed to model the genetic diversity of humans, and having multiple sites helps eliminate kind of you know, a false positive, so to speak. And in these data set, they've enriched rapamycin in the diet provided to these mice. And they're with increasing concentration. So 14, and 42 parts per million in the diet. And what is shown is that there are dose-dependent effects on lifespan extension in both males and females. And to some extent, it appears that the lifespan extension may be relatively greater in female mice. But anyway, this is just one summary of multiple data sets to suggest that rapamycin can extend lifespan. This is I don't want to say easy, but it's a rigorous kind of outcome to study in preclinical models. As you can imagine, doing a lifespan study in humans would be nearly impossible or infeasible, as it would require probably 100 plus years to complete. So in addition to extending lifespan in these preclinical models, there has been a host of data to also suggest that rapamycin delays several age-related pathologies and when dosed appropriately can improve several indices of physiological function. And so one example is the improvement in insulin sensitivity. So the more sensitive you are to insulin, the lower risk you might have for type 2 diabetes. So improving insulin sensitivity, and this is just after a single dose of rapamycin, would be considered a positive outcome. In mice, when rapamycin was given later in their life, so starting in middle age to older adulthood in mice, this actually reversed pre-existing heart dysfunction. So again, improving cardiac function would be a way to help stave off the risk of developing cardiovascular disease. Additionally, long-term rapamycin treatment was shown to combat sarcopenia, which is also known as the age-related loss of skeletal muscle function and mass. So again, the idea would be that rapamycin may be able to delay or slow down some of those age-related losses in physical function. Rapamycin can cross the blood-brain barrier, and in rats, there's been data to suggest that rapamycin can improve cerebral vascular blood flow. And importantly, blood flow in the brain has been shown to decline before the onset of dementia or mild cognitive impairments. So it's thought to be kind of a risk factor. So again, improving cerebral blood flow would be a way to hopefully delay the onset of any cognitive dysfunction. Last, in mice and in humans, especially older adults, so these are adults that are otherwise healthy but over the age of 65, uh, the rapamycin analog has been shown to improve immune function. And this was defined by improving the vaccine efficacy to the influenza vaccine. And I'll share some of those data in a little bit. So overall, some really compelling evidence of all the positive things that rapamycin can do. Limited data in humans, but certainly a plethora of information in mice and other rodents to suggest that rapamycin may be able to improve different indices related to healthy aging. Now, as you can imagine, this is a drug, so there are side effects. I think if anyone were to tell you that any sort of medication or supplement doesn't have a side effect profile, I think you'd want to question whether you believed anything they had to say. So we know that all medications have some risk associated with them, and rapamycin is no different. And so one of the more common potential side effects is elevated blood glucose levels, perhaps insulin resistance, or even the development of new onset diabetes. Some folks have reported increases in their cholesterol levels. And then one of the other ones that, and these all appear to be, I should say, those top four kind of side effects appear to be dose dependent. So the greater the dose, the greater the potential chance of having some of these side effects. The one that does not appear to be dose dependent is some people develop mouth ulcers or canker sores from taking this drug. It's not clearly understood why that might be. But some people are more sensitive to this than others, and we've had a couple reports of that in our studies. But most are mild and transient, meaning they last for just a short period of time. There's also a risk for infections, and I will say that most of these, besides the mouth ulcers, are largely due to people, and I should say patients, that are taking this at very high levels. And so our idea is that if we want to capitalize on some of the advantages of rapamycin, we really want to figure out the dosing regimens that can minimize these side effects in relatively healthy older adults. And we have some data in a model to kind of test. And so this is the only alphabet soup kind of model that I'll be talking about. So hopefully we can still stay big picture here. But we talked about the mTOR protein. And so the mTOR protein actually belongs into two different complexes, complex 1, so mTOR complex 1, and mTOR complex 2. I mentioned mTOR increases with aging. That was primarily related to mTOR complex 1. As it increases with age, this is associated with shortened lifespan and health span, where there's data to suggest that we need mTOR complex 2 to maintain healthy longevity. And rapamycin is unique, or these kind of different complexes are unique in how they respond to rapamycin. So rapamycin will acutely and potently attenuate or inhibit mTOR complex 1, but it will only impact mTOR complex 2 when doses are given at a high level and frequently for a prolonged period of time. So there are some off-target effects where it may inhibit mTOR complex 2, and there's data to suggest that when you inhibit complex 1, this has positive impacts on lifespan and health span. While when you also would it have this kind of secondary or off-target effect on mTOR complex 2, this is associated with a lot of the negative metabolic side effects. This has been shown in different pharmacological studies and different genetic approaches to isolate the signaling cascades of each of these two different complexes. And so this supports kind of our hypothesis is that to really bring rapamycin into human clinical trials in the context of aging, that we really want to preferentially inhibit mTOR complex 1 rather than mTOR complex 2 to maximize health span extension and minimize adverse events. And so one of the ways that we can more selectively target mTOR complex 1 is by using a rapamycin analog or using very low doses or intermittent doses because they will more preferentially target mTOR complex 1 and not have an impact on mTOR complex 2. And there's some data in humans to suggest that this is actually the case. And so this is a study from about 10 years ago. And it was a 6-week trial of using different dosing regimens of the rapamycin analog everolimus. And it was shown to improve the vaccine efficacy. And in order to say this more conclusively, the pre-specified endpoint of this study was that it needed to increase the titer response or the efficacy response in 2 of the 3 vaccine strains that were tested that year. And the authors found that the lowest daily dose, so it's 0.5 milligram per day. So remember, patients take anywhere from 2 to 10 milligrams per day. Met the primary outcome where 2 out of the 3 vaccine tested improved the efficacy. Similarly, what we call an intermittent dosing regimen, where 5 milligrams were provided once per week, also increased vaccine efficacy. They also tested a higher dosing regimen, and this did not meet the primary endpoints because it only improved vaccine efficacy in just one of the vaccines. So these data suggest that these lower doses are actually effective at improving the immune response and rejuvenating some of the age-related impairments in the immunoresponse. Further, it was modeled that these effective doses attenuated the mTOR complex 1 signaling, which again is what we are hoping to achieve. And the side effect profile was actually fairly positive. There were no serious adverse events, which is extremely important, but the most common side effects were, again, those mild transient mouth ulcers, and that was in about 11% of the individuals that were taking the drug at this dose, as well as increased total cholesterol or LDL in 7% of the population. So overall, a relatively low risk profile here, suggesting that these lower daily doses of everolimus or the once weekly intermittent doses appear to be safe, pretty well tolerable. They hit the molecular target of mTOR complex 1 signaling and result in improved vaccine efficacy in older adults. So very exciting data. I will say that the risk profile for this higher dose in regimen, 20 milligrams per week, was, again, they didn't have any serious adverse events, but it increased the number of mild to moderate side effects. As I mentioned, rapamycin is not FDA approved for any context of anything related to aging, but there are hundreds of people taking rapamycin, what we call off-label. So they're able to get this either through their physician or other telemedicine health. And so this survey study um, kind of provided questionnaires to approximately 300 plus individuals who are taking rapamycin or other like-minded individuals who are interested in healthy aging and were not using rapamycin, but potentially interested in using it in the future. And so, on average, these are individuals around 60 years of age. And they found that the rapamycin users reported decreased abdominal discomfort, depression, pain, muscle tightness, anxiety, and even eye pain. Again, these are overall positive outcomes that you would want to see with something that could potentially extend lifespan. The only side effect reported in the individuals taking rapamycin was again people reporting these mild transient mouth sores, and that was in about 15% of the population. There was a recent clinical trial that was completed using rapamycin, and they tested once weekly 5 milligram dosing group and a once weekly 10 milligram dosing group. Now, they used what's called a compounded drug. So they kind of made this drug somewhat on their own. And they actually achieved a dose that was actually 1/3 of the anticipated amount. So if you were to do mental math, the 10 milligrams is actually an effective dose of about 3 milligrams. And the effective dose of the 5 milligram is closer to like 1.5 milligrams. But regardless, this is the adverse event summary comparing the 10 milligram, 5 milligram rapamycin group treated once weekly versus the placebo comparator. And what you can see overall is that the number of adverse events do not differ between the different active drug versus the placebo, suggesting that there doesn't seem to be much of an increased risk of taking uh, rapamycin for 1 year. The results of this study are a little bit hit or miss, but they did show in the once weekly 10 milligram rapamycin group that after taking it for 24 or 48 weeks, there was improvements in lean tissue mass, at least in females. And so again, with age, there's an age-related loss of lean tissue, which is mostly comprised of skeletal muscle. So seeing an improvement in lean tissue mass would be favorable. In the other groups, there was no significant changes. These are all within the kind of error range of the instrument being used to measure lean tissue mass. So there's no change in the other treatments with lean tissue mass. So again, all the studies so far appear to be favorable, meaning that there don't appear to be any serious adverse events. The number of adverse events are relatively similar to that of the placebo group, and there might be improvements in vaccine efficacy as well as body composition. So what remains to be tested here? Well, there's been studies that we talked about, and they're, especially with the vaccine efficacy, they showed that the low daily dose and the once weekly intermittent dose can improve vaccine efficacy, but we really don't know if that dosing or dosing schedule can improve other aspects related to healthy longevity and perhaps delay the onset of different geriatric conditions. A large part of that is the pharmacokinetics, which is how the drug kind of moves throughout our body, and the pharmacodynamics, how it impacts its molecular target in the body, are really limited to young men or patient populations for these companies that wanted to receive FDA approval for different indications. So when we're talking about relatively healthy older adults or middle-aged adults, there's really no data out there. And so we think by closing this gap in knowledge, we will actually be able to identify the appropriate dosing regimen that can positively impact multiple outcomes related to aging and keep its safety profile. There's a lot of information to suggest that rapamycin can improve health span and lifespan in preclinical models, but there's really limited data in whether rapamycin can prove clinically relevant functional outcomes that would be suggestive of improving the quality of life in humans. And so longer term trials are needed. We also don't know how rapamycin impacts other healthy lifestyle choices like being physically active or different dietary approaches. We have some ongoing studies in animals that we're working towards completing right now. Won't be talking about those today. Be focusing more on these first two bullet points. So to help identify this gap, this first gap in knowledge, we have an ongoing dose finding study. So this is a phase 1 trial. Everyone in this study will be put on some sort of mTOR inhibitor medication, whether it's sirolimus, so rapamycin, or a rapamycin analog. And these are in healthy adults, so 55 to 89 years of age. And the goal here is to recommend a dose that could be used in a larger double-blinded clinical trial. And we make this recommendation based off of the rate of adverse events. And so we've defined this kind of what we call dose-limited toxicity. It sounds scary, but we've defined this as a grade 2 adverse events. And I know not everyone is probably familiar what that means, but a grade 2 adverse event is a mild to potentially moderate side effect where you might notice something is happening, but it won't necessarily limit your activities of daily living. So it's more just kind of, I would say, annoying than anything, but relatively has low risk of impairing quality of life. And we kind of chose this really conservative adverse event profile because we were studying this medication in relatively healthy people. So we wanted to make sure that we were maximizing the safety to potential benefit ratio. And so we've identified a rate of adverse events of being of 30%. And this is based off of the FDA label. And so that is our pre-specified endpoint. And I can explain that a little bit more as we move forward. We're also wanted to evaluate pharmacokinetics and pharmacodynamics, so how the drug is working in the body and targeting the different signaling pathways, and then also determine whether the drug has the ability to intervene on what are some known biomarkers related to aging. So if we see at middle age that certain kind of markers in circulation or tissues are increasing, can the drug help restore that to normal levels? And can we use that as potential indication of whether this might actually be working in the terms of age? So this is a 6-week trial. There is a pre-screening procedure that goes on just to make sure that people meet the kind of high-level criteria to fit in the study. Then there's a more detailed in-person medical screening to make sure that it would be safe and appropriate for people to participate in the study. This reviews previous existing conditions and different medications that people might be on to make sure that they're not contraindicated or increase the risk of taking these mTOR inhibitors. After people are determined to be eligible, we have people come into the laboratory in the clinical research unit in the UW hospital, and we collect several different biospecimens, urine, saliva, blood, and skeletal muscle. We also do body composition analyses and metabolic testing. We repeat these tests after the 6-week intervention. Participants also wear what's called a CGM, a continuous glucose monitor. So this stays on the body for 7 days. And it's a little sensor that measures the glucose in our body. And I'll talk about that a little bit more following up. And then participants will be allocated to take once weekly, either 5, 10, or 15 milligrams per week of either sirolimus or everolimus. Every week that people come into the clinical research unit, we studied the pharmacokinetics and pharmacodynamics after the first and the last dose, And then we have this weekly check-ins to make sure that everything is looking okay. We obtain clinical labs just to make sure people are safe, and monitor any sort of adverse events. This just is an example of how we do this. We use the data from each cohort to inform us on what the dose might be for the next cohort. So we do this in cohorts of 3 individuals, and this would be 3 males and then 3 females. And so we have the different doses on the y-axis here and the number of participants we aim to complete in this trial. And this is just a hypothetical scenario. But basically what this means is if we have 3 participants go through the study and 1 participant reports a grade 2 adverse event or a dose-limited toxicity, that would mean that 33% of the individuals had a dose-limiting toxicity. We have these criteria to inform us on whether we escalate, retain, or de-escalate the dose for the next cohort. Because it's 1/3, it fits these metrics of retaining the dose. So the next cohort of individuals also receives 5 milligrams per dose per week. And then you can see in the third cohort of 3 individuals, there were no DLTs. And so in this total of 9 participants, we've had only 2 people experience any side effects. This would meet the criteria that we could escalate the dose to 10 milligrams. So we basically base the dosing regimen of the subsequent cohort based off of our accumulated data and knowledge to make sure that we minimize placing people on a dose that may either be ineffective, so we don't want to waste anyone's time and resources, and we minimize the potential of putting them on a toxic dose where there would be more risk than is warranted. And so this is a study design that is supposedly superior than other classical approaches and has been adopted from some of the ongoing cancer research to look at different cancer treatments in individuals. So we have measured the pharmacokinetics in just a small cohort just to make sure that we were achieving the anticipated levels in the body and to inform whether we needed to make any sort of like dose modifications based on these results. And we were happy to see what we were expecting to see. I would say that. And so what we do is we collect blood before, half hour, 1.5, 4 hours, and again, 48 and 168 hours after they consume the first dose and after they consume their 6th dose. And what we find is that the values are repeatable, they're consistent, they follow the first order kinetics that is common in the pharmacokinetic world, and they achieve peak values that we have found to be similar in some of the previous literature. We also show here that after each dose, there is a peak, but it comes back down towards very low levels, 48 hours to, so basically 2 days to 7 days after they take the dose of everolimus. And so we think this is a safer approach. We think having lower levels around will decrease the risk for side effects as it relates to mTOR signaling. And I think these data are promising to help support that goal of testing how we can specifically inhibit mTOR complex 1 to modify the biology of aging. As I mentioned, we use continuous glucose monitors. These are commonly used in people with diabetes, whether it's type 1 or type 2. And so a continuous glucose monitor, basically there's this sensor and transmitter, and then there's this little thread that comes off of it. And it's about the size of a string. And so this string has a sensor on the end of it, and it's inserted underneath your skin. It stays there. It's very flexible. It's you don't even notice it. It sits on your abdomen region for 7 to 10 days, and we are able to collect glucose readings every 5 minutes, which means we get 288 glucose readings per day. And across 10 days, that's almost 3,000 data points of blood glucose. And so we like this approach because what we've noticed is that when participants come in overnight fasted to obtain a fasting blood glucose level. Oftentimes, as indicated by the green arrow here, we see that patients have relatively similar levels of their fasting blood glucose, but it overlooks the different variability in response to glucose throughout the day. And so these are three different individuals in the red, the black, and the gray. And it just demonstrates how if you were to take a fasting blood glucose, it would not capture, especially in the participant who's indicated in red, the high levels of glucose variability and spikes that you see throughout the day. And we know that glycemic variability, in addition to just fasting markers, are related to the risk of metabolic and cardiovascular disease. And so in our trial so far, it's not statistically significant yet because we only have a 10 to 12 individuals that have completed. But what we're noticing is there's a trend to reduce one indice of glycemic variability, which is the average daily risk range. And this index captures the risk of hyper and hypoglycemic or high or low blood glucose events. We've also seen this index decrease with exercise. So to see it respond in a short amount of time, just 6 weeks, potentially in a small number of subjects, is a positive. We would think this to be a positive potential outcome. We've One of the things that the CGM does is it measures glucose behavior in free living conditions, which can get a little hard to analyze. But we also do a standardized challenge where we provide 75 grams of glucose in the form of an oral glucose tolerance test. And then we are able to evaluate how people respond to that glucose challenge. And these are data from the CGM. So the glucose values on the y-axis and time on the x-axis. And we see that the glucose goes up, but then comes back down within a few hours. And there appears to be no difference before and after taking everolimus. We also are measuring how people perceive their kind of social, physical, and emotional well-being. And one thing that popped out is people reported having an improved emotional score. So kind of improved feelings of emotional health. And we are not the only ones that have showed this. The Pearl trial that I talked about, lean tissue mass changes, also reported that in the 5 milligram dose, there was an increase in their emotional well-being score. However, in our study, we don't have a placebo comparator for this first trial, and there are some significant placebo effects as well. So this very well could be a placebo effect, but it's certainly important to note that at least we are not seeing any sort of decreases or no change in emotional well-being. So this study is ongoing, and we think by identifying the safety of everolimus with our really sophisticated, what we call multi-omic approaches, where we'll be able to understand how different genes, proteins, different modifications of those things can be altered by the drug to improve potentially healthy aging, as well as how we can do different sophisticated pharmacokinetic and pharmacodynamic modeling may lead us to identify the most safe and effective approach to modify the biology of aging. We have another study. This is a phase 2 trial. This is, which means it's a randomized, double-blinded, placebo-controlled trial. And so it's a larger study and it's longer duration. So we are aiming to determine if everolimus for 24 weeks, either receiving the 0.5 milligram per day or the 5 milligrams per week, which was shown to improve vaccine efficacy, if it can promote improvements in multiple physiological outcomes and improve the biology of aging. So again, participants go through a very thorough medical screening. And then before they start the study drug, people again are on continuous glucose monitors before, during, or towards the end of the trial. And then they come in for several visits to evaluate body composition, physical capacity, muscle sampling, which is optional. You don't have to do that for the study. Metabolic testing. We evaluate cognitive function through both brain MRI and cognitive executive function, as well as evaluate heart health through a standardized clinical echocardiogram. We also have participants complete different questionnaires related to different conditions, such as lower urinary tract symptoms, physical, emotional, and cognitive well-being, different pain indices, as well as sleep quantity and quality. We use what's called a double dummy design, which means we have three different groups that participants are randomized to in a one-to-one-to-one fashion. So there's 1/3 of the chance you'd be in placebo, and then there's 1/3 of the chance that you'd be in either of the active treatment groups that only differ by the time or the dosing, kind of the dose that they're taking. So it's either 0.5 mg per day or 5 mg per week. So every participant will take a pill from once daily from one bottle and once weekly from another bottle. This allows us to stay blinded between the active and the placebo drugs, so basically everolimus versus placebo, as well as the different frequency of dosing of the everolimus. So it's a really rigorous way to make sure that we're not biasing either subconsciously or consciously any of the outcomes that we will be measuring in the clinical trial. And so we have a lot of endpoints that we're interested in, with the goal of understanding whether 24 weeks of everolimus will selectively inhibit mTOR complex 1 and improve metabolic, cardiac, physical, and cognitive function. By using different indices, our primary outcome is glucose disposal through an oral glucose tolerance test that I sort of described previously, as well as other indices of glucose metabolism and homeostasis. We'll also look at cardiac health through echocardiogram. We'll do VO2 max testing and muscle strength and power testing for physical function. And then cognitive will be a cognitive evaluation as well as brain MRI. We are particularly interested in middle-aged to older adults who either have insulin resistance or prediabetes. So age 55 to 80, who have either prediabetes or insulin resistance. The reason is that not only is there an age-related increase in mTOR signaling, insulin resistance and prediabetes seem to exacerbate that and also compound the risk of age-related conditions such as type 2 diabetes, cardiovascular disease, frailty, and dementia. And so as you can probably appreciate, we are evaluating metabolic outcomes that are clinically related to type 2 diabetes, cardiac health related to cardiovascular disease, physical function related to frailty, and cognitive evaluations related to dementia. And so we're motivated by this because when mTOR complex 1 signaling has been attenuated or inhibited, it has been shown to improve a lot of these conditions in model systems. So this will be the first study to identify whether this holds true in humans. We also have a young control group, so 18 to 35 years of age. They don't actually receive the study drug. They complete all the baseline studies that all the middle-aged to older adults will complete. And it kind of provides us a kind of a positive control. So basically, if this drug is effective, we want to make sure that any changes in the biology as well as physiology are shifting more towards that younger group, and certainly not in the opposite direction. And we have preliminary data to show that there are age-related differences in glucose tolerance, where we have the older adults in the circles, and you can see their glucose levels are higher after the glucose challenge compared to their younger counterparts. Similarly, we have different indices of diastolic function. So this is the ability of the heart to relax, fill with blood, and contract. And sure enough, the older adults seem to have age-related changes compared to their younger counterparts. We're also looking at skeletal muscle power production. So how fast can people move a certain amount of weight? And again, the older adults have lower muscle function and contractile velocity. And then this is a representative image of a brain MRI We have a younger individual who's a graduate student versus an older individual age 74. And what we can see is that 28-year-old has lighter colors in the vessels of their brain, suggesting a higher brain blood flow compared to the 74-year-old counterpart. And so again, the idea is hopefully we will be able to see the everolimus group shift some of these variables towards that of the younger healthy control group. And so just to, kind of wrap things up is that when we're thinking about rapamycin or any sort of other compound or lifestyle intervention, with the idea of improving healthy aging, we really need to improve physiological function throughout the whole body. So just improving immune function is great. Certainly, that's definitely a positive thing. But in order to target multiple, conditions related to aging, we really want to improve upon multiple different tissues. We are testing this working hypothesis that select inhibition of mTORC1 may be geroprotective or help, delay the onset of these chronic conditions that we often see with aging, and avoid any of the or minimize the risk of side effects through inhibition of mTORC2. At the completion of both our phase 1 and our phase 2 clinical trials, we really think that we're going to be able to identify the appropriate candidates to be on a larger scale trial. What are the safe and effective dosing regimens, and then what sort of primary outcomes can be tested in these larger trials? So with that, I definitely would be happy to take any questions. I do have the contact information here in case anyone might be interested in learning more about these studies. We are actively recruiting and these studies are ongoing. So we'd welcome anyone who is interested in learning more to please contact us. This is my research team. We can't do these really highly controlled, very much needed trials without the dedicated work of the team, and of course the funding. So these trials are funded by the National Institutes on Aging, which is one of the institutes in the National Institutes of Health. So in other words, you are paying for these studies from your tax dollars. So I will hopefully continue to share any sort of results that we find from our studies, so you can learn more about what your money has gone to good use for. So with that, I'll be happy to take any questions that might be had.
Well, thanks very much, Adam. If you're wanting to submit a question, would you please do it through the Q&A um, icon that you see at the very bottom of the screen rather than using the chat? I don't see any questions, but I'll give you a few minutes to think about that and let me well, Adam can see these questions as well as I can, but anyway, let us know if you have questions that you'd like to ask. So Adam, could you say a few words about what mTOR means uh, and why you're looking?
Yeah. So mTOR is just it's just an abbreviation. So it's an acronym for mTOR complex, or excuse me, mechanistic target of rapamycin. So that's kind of its definition. But mTOR itself is related to protein metabolism, glucose metabolism, fatty acid metabolism, the growth of organisms and tissues. It has its hand in a lot of different areas. And so I think when it becomes dysregulated with aging, it can be kind of conducive and allow some of the age-related changes in physiology to occur.
So there's a question, can you speculate on differences between males and females in response to rapamycin?
That's a great question, and hopefully, as you saw, we are including both males and females in our human clinical trials to try to understand that. There are data in mice to suggest that the lifespan extension of rapamycin is relatively greater in females versus males, and that circulating levels of rapamycin, even with the same dose, are slightly higher in females versus males. And we don't know if that is something inherent in how, sex differences in metabolizing the drug, or if it's due to body size or some other potential factors. And um, so there have been some sex-specific effects in preclinical models, and we are certainly going to evaluate that in our human clinical trials as well. I think it's a very interesting question that needs to be better defined.
And
And
there's
I see,
and are there
yeah,
any concerns about cuts in federal funding for research that we're reading about in the media these days?
yeah. So, great question again. I was telling Millard here before we got started is most of the money for our clinical trial supporting or for our grants that are supporting these clinical trials are already on campus. And so I never want to say, never say never. But since the money is already here, it's a little bit more challenging for the NIH to take that money back. So I think from that perspective, we are in a good position. Obviously, there always could be something that comes up. The other, I think, aspect that helps us is that I think, regardless of political affiliations or who you support in, presidential elections, I think most people can agree that we are all going to get older, and we all are aging. And so, if we can understand aging and how to age in a more healthy way, then I think that's going to be really impactful and significant research, regardless of your beliefs on anything else. And so, I think from that perspective, we are not under some of the similar scrutiny that other more polarizing areas of research might be undergoing right now. So I'm hopeful that we will have minimal impact. Now, that's not to say that we're currently confused and unclear of what the impact are on future, grant applications and future research to support the really important research that's being done here at UW-Madison. So I think the impact of federal funding will be seen in many years to come because of some of these items. But right now we are in a pretty good spot. Okay, the next question is rapamycin related to Rapa Yes, it's the same thing. So, rapamycin was first discovered in the soil of Easter Island, um, and primarily used as an antifungal agent for a while. And so, yeah, that is a shared origins.
Let me ask you a question about controlling behavior of people who are involved in clinical trials. Do you do anything to try to minimize variations from person to person by giving them a protocol that they have to follow with respect to exercise, diet, other life activities?
Yeah. So certainly those factors can play a role. So we ask people not to change anything is really what we do. So we don't want people to start our study and then go out and start a rigorous exercise training program. Now, if people are already active, that's okay. Again, we just don't want people to become sedentary or increase their levels of physical activity. Because essentially we're going to be measuring the change relative to their baseline condition.
Mhm.
Now, as you can imagine, that can potentially introduce some variability. We are subjectively quantifying physical activity. We also have dietary logs to try to get a high level overview of what people's macronutrient composition in their diet. And so that way we can do some secondary analyses or exploratory analyses to see how those factors play a role in any of the outcomes that we see.
Mhm.
So absolutely. And there's a question, are people paid for taking part in the study? Yes, absolutely. So we pay people for their time. So for the 6-week trial, it's either five or $600, and then for the 24-week trial, the phase two, it's $2,000.
I was wondering about the uh, things that you monitor in your patients and in these studies. I didn't see anything about osteoporosis or arthritis. Do you do anything? Is it changes in skeleton too slow to?
So yeah, so for like bone, we it's from the DEXA. So I don't know. I think most people probably receive DEXAs, but DEXA is basically an X-ray, kind of Xerox copy of your body essentially. And so we are able to look at fat mass, fat-free mass, and bone mineral density and content. Generally, from a study population of this size, I don't know if we're going to be able to see some of the small differences that would occur over 6 months. As you alluded to, the skeleton takes a little while to change, but certainly something that we can look at and explore. And then for arthritis, again, we don't have any real specific measures of arthritis, except for we do have a survey. This is the Western Ontario um, oh, I can't remember what it stands for, but it's a joint pain scale. So we can see how people self-reported evaluations of any joint pain may change before and after the trial. And if there are, some benefits, then that could perhaps lend itself to being more arthritic related outcomes being involved in other kind of study designs.
Yeah, I don't see any other questions coming from our audience. So I will just say on behalf of all of them and on the Retirement Association, thank you very much. This was a very informative webinar. It's an exciting topic. It'll be interesting to see if it's possible to do anything to, in a fairly easy way, put off the damage that's done by aging. I'm beginning to appreciate just how much aging affects the human body. I'm now 90. So,
Yeah.
and beginning to slow down a lot. So, anyway, thank you, Adam.
Well, thank you. And I hope if it is of interest to the group, I'd love to come back in, a couple of years when we have these studies, finished so I can kind of share some of the results of what we learned and determine whether or not everolimus can be effective in humans like it has been shown in some of these preclinical experimental model systems.
Yes, well, this is definitely a subject of interest to people in the Retirement Association, and I look forward to hearing what you have to say in the future.
All right. Thank you so much
Thank
for
you
having
very
me.
much.
And if anyone does have any questions, you can feel free to contact us at this email address or phone number. So we'd be happy to address any questions.
All right, well, I think that does it for us today.
All right. Thank you so
Thanks
much.
all of you for attending, and thanks, Adam, for a fascinating webinar.